Thank you, Gox, for inviting me to come together to have a chat with all of you. And it is a privilege working with all of you. And I think one of the things I mentioned with the talk to CMC yesterday and some mission hospitals is it's great to be working in partnership. So I think if I briefly tell you how this scene could progress, it may be useful to start off with. So, and then I'll go from there on to say.
Okay, welcome everybody, and Johnson, please carry on.
Okay, so thank you. So what I'll do is I'll tell you the progression of the disease in the UK, and in many ways, because India seems to be about 4 to 6 weeks behind where the UK is currently, and in some ways we've learned from Italy and Spain, and we were about 4 to 6 weeks behind them. So it may be useful for us to look at the progression and how things have panned out here. And we are just praying that it won't pan out like that in India. I'm hoping and praying it won't pan out like this. But if it does, then what do we do is what we need to do. So I'll talk about how we have moved from almost no cases to pretty much most hospitals doing only COVID now. And then I'll tell you about the preparedness that we have done. And then I will make simple suggestions for what may be useful in the mission hospital setting and in the smaller non-big city hospital setting. So there are some things which we can universally have a takeaways, in the sense that there are some things which are general principles which will not change whether you're working in a tertiary care hospital or whether you're working in a 5-bedded hospital. So that's what I hope we'll do. And then obviously we can have time for questions, and feel free to ask anything in between, because I don't want to go to anything in detail, but I thought I'll just do some outlines. So if I may start and say, how did it start here? I mean, the whole landscape has changed in the last month. So we are the 12th of April. The 12th of March was a normal working day in the UK. So life has gone from a normal working day with, there is some COVID in a hospital here or a hospital there, to most hospitals in the UK being converted to COVID hospitals. So when we first started, the risk factors, as you call it, was, has anybody been to China in the last 2 weeks? So therefore, the history was, if you've been to China, and then have you been to northern Italy, and then to some parts of Spain? It has gone from there, from the history, because it was all transmitted by travel from people outside, to within 2 weeks, it started becoming community transfer. So we no longer ask for travel history. So travel is completely gone out of the window. It's important because I've seen some of your risk protocols sent by some of the, looking at some of the government and NGO organizations in India. And there is always a high risk about travel. So this is exactly how we were about 4 or 5 weeks ago. So there is a possibility that other than your imported cases, you have people coming from abroad, and I've seen your clusters coming from the groups in Delhi and clusters in different places. It can have a huge community spread. So that is something which you need to be aware of. Now, in the UK, it has spread for a variety of reasons. I wouldn't say we were not prepared. We were reasonably prepared as compared to America was, or even Italy was. The transmission routes are quite important. There are 2 big transmission routes. One is your aerosol or person-to-person transmission, mainly due to droplet, which means when you cough, there's a big lot of droplets come out, and there are aerosols which are much smaller. So those are the 2 big routes where these things can sorry, that's one route where you can transfer. There's person to person. The other one is by fomite transmission, which simply means that your virus is there in the environment, which means on plastics or hard surfaces on doors or windows. The question about shaking hands, because it's there on your hands, and then it goes through your respiratory system. Or touching infected material. Now, we have looked at, well, there is some evidence, I wouldn't say we have looked at, there is some evidence coming about how long the virus can survive. It can survive up to 72 hours on some surfaces, and maybe up to 96 hours on some other surfaces. But looking at some evidence coming out of China, heat seems to have an effect. What it means is this is an extrapolation looking at the number of cases which happened when the temperature was 0 degrees and the temperature when it went above 30 degrees. And there's a dramatic drop in the transmission. So there is a postulation that the virus, and there is definitely evidence, a paper published in the Lancet looking at more than 60 degrees centigrade, which is actually very hot. We don't get that sort of temperature, but upwards of 30 degrees, there is a suggestion that the virus can be inactivated early. So I'm not entirely surprised that India hasn't exploded, because temperature in most parts of the country are well above 30 degrees now that we're approaching or into summer. So there is a possibility that some of the transmission that we're seeing in the West, in the UK and Italy and in America, where the temperature is well below 30 degrees now, it is directly due to the droplet and aerosol and due to the fomite. So probably in India, it's mainly happening through the droplets, although you need to make sure that you wash your hands and such like. Please follow hygiene. But there is a small suspicion that there could be a difference in the transmissions. So if that is the case, then it is good news for India and for the tropical countries, simply because if the virus is less active, at least you have only one major route of transmission, which is in direct contact with the person, and they're coughing within 2 meters distance or 3 meters distance of where you're standing. So there is a slight difference. So we need to keep that in mind. But here it exploded from, as I said, from the 1 or 2 cases to entire hospitals becoming COVID hospitals. And that happened very, very rapidly. So when it first started, there was a standard thing about asking about history of travel from elsewhere and asking about cough and looking at the, waiting for PCRs to come back. It takes about 3 to 5 days for the results to come back. And we used to put them in COVID suspicious wards. And if you had a COVID positive patient, it was all hell breaking loose and the whole area was sort of cordoned off, sort of thing, something like what's happening in India. So the question is that all really necessary, or was it useful? I don't think so is the answer. For the simple reason that we had community spread here and people were coming in leaps and bounds through the door. So when they first started coming in, each ward in the UK, in any of our hospitals, has got about 4 or 5 side rooms, single rooms. The rest of them are 4 patients per bay, wards. And then you have an area which is a bit more high dependency in each ward. So initially what we did was to put patients in the side rooms in the respiratory wards, because they are admitted for respiratory reasons. And I'll tell you what are the criteria for admission, and it'll be useful to follow that in India as well, because it's a very simple guide and very useful to use it. So we used to put them in the side room of the respiratory wards. Treat them with total isolation, and there used to be this PPE outside and only one nurse would go in. So then as the cases started increasing, we didn't have enough side rooms in the respiratory wards. We started moving them to the side rooms in the other wards. These are patients who are suspected COVID. I'll tell you why it's suspected in a minute. So we started putting them there, and then we started using every single ward in the hospital, going from the medical wards to the surgical wards, using the side rooms. But that came up with a big problem. And the problem was there were lots of people dealing with COVID patients, and there was lots of PPE being used as well. PPE is the personal protective equipment. So, those were the days when we were not we didn't have PPE all over the place for everybody to use. So we don't wear visors and walk around normally. The reason it was in the chest ward is we have negative pressure rooms for the tuberculosis, multi-drug resistant TB patients. So we are used to it, but we had only 2 rooms and they were all used up, one room and it was used up very quickly. We started going across the hospital and then we found that it was more labor intensive to getting many nurses doing what could be cohorted in one place. So then we started cohorting all the COVID suspicious patients into one place. And then it started going on to we overshot the respiratory wards. We have 2 respiratory wards, we went on to the other wards. That's how it goes. Are you okay?
Yes, we are okay. Yeah. Please go ahead.
Okay. So that's how it went. So, which brings me very nicely to who are the ones that we diagnose. So right from the beginning, in the UK, which is not a bad strategy at all, is to make patients or isolate patients in their own homes. Now, India has got a slight problem in that, I understand, but here it was feasible because we wanted patients to isolate in their own homes and have all the family members isolate as well. So so even general practices stopped seeing patients. So there'll be a board outside saying if you have cough, fever, headache, myalgia, and if you've had foreign travel or any contact with foreign travel, don't come inside, just call the number. So if anybody had such a symptom, the patient would have to isolate. Suppose I had a symptom, I had to isolate myself at home for a week, and my whole family had to isolate for 2 weeks. Reason being, the incubation period goes on for up to 2 weeks. So if somebody else gets an infection, then the remaining people will isolate for a further 2 weeks and such like. So we've asked people to isolate at home and we were not testing them. We were presuming they had COVID, but we did not test them. The only ones we want asked to come into hospital are the patients who were very unwell. And what does it mean? It means patients who had breathlessness and cough. Not just cough, really breathlessness and extreme fatigue and unable to manage at home. So then we started looking at, so patients started coming in through the emergency. So each emergency department, I know mission hospitals also do have a casualty, as we call it. So one area of the casualty was sort of cordoned off. I said this will be a COVID entrance and the rest will be every other entrance. So even from that's how it started in the ED, emergency department, and now there is only one entrance to the ED, which is the COVID entrance. Nobody else is admitted through the emergency. There's some emergencies that we have one small area. So if you look at from 99% of non-COVID and 1% of COVID about 4 weeks ago, we are now 95% COVID and 5% non-COVID. So that's our shift in the emergency department. So when they come through when they first started coming through the emergency department, they would be swabbed, and the swab is a nasopharyngeal swab, and the nasal swab is better than the pharyngeal swab. So, but some people are more used to doing a pharyngeal swab. The sensitivity is only 65%, which means 1/3 of the patients will miss, and the results came back 5 days later. So we were treating them anyway in a cohorted area. So that's how it started moving across. And how did we presume that they were COVID patients? In the initial days, we used to have some contact with somebody coming from abroad, or there was a big group which came back after skiing in Italy, where Italy already had COVID. But soon we started realizing that this contact business doesn't work. They had very classical features, and the features which they come in with, all of them are breathless when they come to hospital. All of them most of them have a dry cough. A lot of them have high-grade fever, and they have extreme myalgia and headaches. Some of them have sore throats. But when you do a chest X-ray, there is a very classical picture on a chest X-ray. You do get interstitial patchy shadowing, and mainly in the peripheries on the sides of the lungs, not really close to the heart. And when you do a blood test on them, they used to have a high C-reactive protein, CRP, And in the full blood count, the differential count, the lymphocytes will be less than 1. So it's a lymphopenia with a normal leukocyte count. And these patients were all hypoxic. And many of them were in their 40s and 50s, previously well patients, and they're coming hypoxic with this picture. So before the COVID days, if you had something like that, you would think of some rare, wonderful diseases like atypical pneumonia or HIV-related diseases or parrots and bird fanciers disease and that sort of thing. But patients started coming in through the door, left, right, and center, people who have not been abroad, not been exposed. So these patients were cohorted straight into our COVID wards because we were almost certain that they were COVID. And believe it or not, most of them turned out to be COVID. Even the 1/3 who didn't turn out to be COVID, we still treated them as COVID because it couldn't be anything else. The picture was very, very classical. So that's what we do to admit patients. So who do we admit? Patients who are symptomatic. And we have 2 strict criteria. If the patients are well and can be managed at home, we would discharge them. And what does that mean? If they have a breathing rate. So 2 big features which you need to have, and I'm sure, well, one is the clinical stuff, which is counting the respiratory rate, which we can do everywhere. A respiratory rate more than 25 in a resting patient who's otherwise well means the patient has got some sort of respiratory distress. More than 30 is what they usually have, but 25 to 30, we used to give them the benefit of the doubt as well. More than 30 is definitely abnormal. And we have a pulse oximeter and check their oxygen saturation, so which can be done in every mission hospital as well. So that we admitted patients with a saturation less than 94% on room air at rest. Many of them, if you make them walk about 10 meters, their saturations, if it's 95, can drop to 92. We were not admitting them. They are all known to have exercise drops in their oxygen saturations. But we admitted patients with a saturation, and still do admit patients with a saturation less than 94% on air at rest. So that was our criteria for admission, which can be one thing which can be done in India as well. As I said, there are some differences. When we send them home from here, they go to their own homes, which usually don't have more than 4 or 5 people per home. I understand that in some rural places, you can have overcrowding at homes and there may be one room and you can't ask them to isolate, because how can you isolate in a one room hut or small house? It's going to be difficult. That's something which you need to think about. So would you admit those patients to ensure that the rest of the family is protected? Because here we don't admit them to hospital because we know that people can spare a room in most houses, and so they'll be in their rooms. If you ask them not to come out of the rooms, food is left outside the doors, and there'll be a window which they can open in between, and everything is, and they have their separate bathrooms and such like. So that can be difficult in India, I understand. So something for the mission hospitals to think about is, do we admit everybody who's got symptoms, or could we send them home depending on what is home? Something to think about. I was just looking through Gokavi's, the write-up, and it's a very useful thing to give us a very interesting perspective of what can be the situation at home. So our admission criteria may not necessarily work in the rural hospital setting in India, but it's worthwhile having a protocol, I think, saying that if it's possible for a person to be isolated at home, it's better the person to be at home than in the hospital, provided they can bring the patient back if the patient deteriorates. That's the other question as well. Here, we give them that, information, and they will bring them back. So travel, transport, and such like, you need to take into consideration. So I leave that with you, something to think about. But the last thing you want is to fill your hospital with patients with mild disease, so you can't admit the patients with severe disease. So it's something which we need to think about. So I told you briefly about how the disease progressed and what we did in the wards for them. But once the disease started, becoming more and more, community transmission started happening, we started seeing lots of patients coming through the door. So then we decided about 3 weeks ago now, we will stop all elective outpatient activities. So outpatient activities were stopped. So we don't see any outpatients, because outpatients are overcrowded areas. As you can imagine, social distancing is not possible. And all you need is people sitting there and coughing, a nice place for things to spread. So we stopped outpatients. Something to think about, whether you need to carry on with outpatients or only see patients who are really sick. Do you need to really see the do you need to have a diabetic clinic? Do you need to have a clinic for your heart disease or hypertension and that sort of thing? So something to think about. We stopped all routine clinics. The only clinics which run are some target clinics, which means cancer referrals are seen. The rest of them were cancelled. The same when, just shut this door down. The same when happened for surgery. So we knew that the patients are going to get admitted with breathlessness. So progression of breathlessness means needing a ventilator, and therefore we have limited ventilator availability and ITU beds. We did not want an elective patient to use a ventilator. For example, aortic aneurysm repair or a major GI surgery which can afford to wait, or even a coronary bypass surgery. So we stopped all elective surgery, and for the last 3 weeks we've only been doing trauma, which means there's an accident which happens, or emergency surgical procedures, or if there's a curative cancer surgery. So that also freed up a lot of our intensive care beds. So something for you to think of in India is, what do you do for your outpatients? Is there really a necessity to have outpatients? And some private hospital their income may depend on your outpatient, but you need to balance the risk and the benefit. A tip which may be useful, which the first 3 weeks, even before we started this cut, so we're in April now, sort of from the beginning of February, when you ring a hospital for an appointment, the first thing which messages comes about is, if you travel to Italy or Spain or China, or if you got fever, cough and blah, blah, do not come into hospital. So that's the first message. Only then can you connect. And even if you come into the hospital, for example, our private hospitals here, they would only let the doctors, nurses, staff, and patients in after you check a temperature. So they used to have a temperature check. Something to think about. It's not the best test, I must say, because there are always ways around it, and you need not be febrile at that particular period if you've taken paracetamol. But it was a useful method which you may think about if you have to have an outpatient department to check a temperature, and somebody who's got a temperature and has got cough, it's best not to ask them to come and sit in the general outpatient department and possibly infecting others. So those are two things which you need to decide depending on what your hospital needs are, what's your outpatient population and such like. But this is what we have done in the UK. So once you're admitted, so as I said, initially the patients were in our respiratory wards, and we, right from the beginning, because we admitted as I said, we admit patients who are saturation less than 94%, and quite a few of them needed lots of oxygen. And we used to give them non-invasive ventilation called CPAP, continuous positive airway pressure ventilation. And that can produce a lot of aerosols, and that can spread. So we were very, very careful in our respiratory wards. We used full PPE. That means using our surgical gowns, full gowns and mask and visor and the FFP3 mask. Despite all that, we have 7 consultants in respiratory medicine, of which 3 of them have got COVID, and 2 are just recovering. 1 is not too well, and 3 of my 8 registrars have developed COVID, and 8 of our nurses in the respiratory wards. So quite a few people, despite all this, still developed the infection. Now you may ask, how did they get it? They could have got it well before we did all this. But the other big caution for everybody is, we are using FFP full PPE, but never be under the illusion that you're protected. Never let your guard down, because it is very, very difficult to carry on using full PPE, and it's very, very suffocating and difficult, because by the time I finish my ward round, taking about 2 to 2.5 hours to see my 22 patients in my side of the ward, it's about I start feeling I start getting a headache, because you start rebreathing into this mask. So nurses and others do take the mask off to breathe, because we do the rounds, we go out, but the nurses are there for 8 hours, and the most vulnerable group is the nurses. Something for you to remember, because as doctors, it is our duty to protect everybody who works with us. And I think among the healthcare workers, the most vulnerable are the nurses, and we forget that. that. So please do keep that in mind when you do this. So we started cohorting them to the respiratory wards, and as the numbers grew, we started moving them to different wards, which is something which you will have to consider. What ward will you use first? So I know many Indian hospitals do have isolation wards. It may be a good idea to start with the isolation ward, and as it spreads beyond that, I would strongly suggest that you designate. Wards and call them as COVID wards. So once one ward is filled, start with another ward and then filling that ward. It serves a good purpose because at least you know where this thing is concentrated. You can keep all your PPE in one area. All the staff in those places can be, as we call the dirty wards. And the other wards can be the clean wards, and you can admit other patients there. But if the explosion hits, then, at the moment we have, I think the only ward which is not COVID ward clearly is one side of pediatrics ward, obs and gynae, the labor room, and maybe about half a medical ward. Because all the surgical wards, we don't have any surgical patients except for the ones who had emergency surgery. So most of the hospital now is COVID. The next question you'll have to ask yourself is how much you have to escalate treatment. That we started asking ourselves. We had about 15 beds in the main hospital and 20 beds in our cardiothoracic center, which is also on site. But that was only for cardiothoracic patients. But once we stopped doing cardiothoracic surgery, elective procedures, we started using all the ITU beds for COVID patients. So we had 35 beds. But we soon ran out of those 35 beds. And now we have close to, this morning I finished, there were 65 patients as of this morning on a ventilator. So they were able to get more ventilators and so on and so forth. We'll come to that in a minute. So the question you need to ask yourself is, who will you put on a ventilator? So there are some criteria which we use here, which I think all of you have to use some criteria or the other. And in the UK, at least, we don't worry about the money side of things. So nobody pays to come into hospital. The NHS, by God's grace, is a free quality service. So nobody has to pay. So we don't have to check and see, can you pay this amount or that amount? I do understand that many mission hospitals maybe have a problem with the resource. There are private hospitals, obviously, where the income comes from patients. Not sure what happens to the government hospital, but I presume it's free. So that's something we need to think about. But if I take the money out of the equation and look at the clinical side of things, we have set criteria, and we go from low flow oxygen to high flow oxygen to CPAP, which is continuous positive airway pressure, and then we ventilate. Unless the patient is suddenly going off or they come in, we know that CPAP is not going to be useful, so ventilate straight away. But do we ventilate an 85-year-old person who's got ischemic heart disease and got a bit of heart failure and got a bit of COPD and some diabetes? The answer is no. So we have definite criteria. So I have given Gokavi some criteria that we use here. So I'm happy for it to be shared. But as I told the group on 83 batch day for yesterday and the Vellore group yesterday, what we do here may not be the right thing for you, but it may be a useful thing to have to you to decide what are you going to have as your cutoff. Because there are two things you need to keep in mind. One, will the patient survive by putting them on a ventilator? And two, how many of my ventilators am I going to be using? Because once you use up all your ventilators, there'll be still if patients still come through the door, what do you do with them? So you want to use the best use of your ventilators. Sometimes you may feel like you're playing God, but when you have limited resources, there's something which you need to think about, which is why having a criteria and sticking by the criteria may be useful. And obviously, any criteria or protocol, clinical judgment is important, but it's useful to have criteria so that we all sing from the same hymn sheet. So we have criteria, and it's based on three big things. One, the biggest thing is the comorbidities. That means what are the other things going on, and that's the first thing. And the second thing is what is your previous functional status. So we have what's called the frailty score, and it's there in So this is what we use here. You may have different scores there, but the one we use is very, very pragmatic and useful. And I find it extremely useful. And anybody can put those things together. It's a structured one. It comes with points. It's useful to do that together. That's the second thing. And third one we use, not the first, that's actually an ancillary one, is the age. The reason I say age, or we use age, is although we are not discriminative on the basis of age, we do know the outcome for patients we put on a ventilator. And it's sort of inversely proportional to the decade of your age. For example, a 60-year-old man has got a 40% chance of surviving, while a 40-year-old man's got a 60% chance of surviving the ventilator. And there is some evidence looking at the work and the ICUs in London and the Boston group. Once you cross day 5 on a ventilator, you're going to usually go up to day 12 and 13, and then your survival sort of steeply drops. So why did I mention all this? So you don't want to put somebody on a ventilator you think will, the normal course, you're happy to give them 2, 3, 4 weeks of ventilator treatment, but if others come across only need 2 days of ventilator, are you actually denying them? Something to think about. I know it's not the best of ways to look at it, but it's useful to have the criteria. And that's the hard fact. I mean, that's the survival rate. And as of day before yesterday, the Intensive Care Society has just come up with the mortality rates in intensive care in the UK. And these are all very good ITUs. And it's 52% mortality overall, as compared to 24%, which was pre-COVID era. So, mortality is doubled in this group. And a lot of these patients are not old patients, they're young patients. Because we quite liberally write this escalation policy, and many patients with multiple comorbidities don't even go onto a ventilator. I'm talking about patients who are actually on the ventilator. So it's something to think about for mission hospital setting and private hospital setting, and even large hospital settings. What are the criteria that you're going to put across? So you could use some of the things which I've told you, but you may want to modify it according to your needs. So what works in a small mission hospital may be different from somewhere else, and what is in a 15-bedded ITU may be different from a 5-bedded ITU. So you really have to work, it's a horses for courses really. But these are useful guidelines to have. So that's the patients who go for ventilation. The next level is the non-invasive ventilation. I know it's not very old, because I've been doing it here for the last 15 years. But when I was working in Vellore Medical Mission, and even before in Vellore, we didn't use much of non-invasive ventilation regularly. So I'm not sure how commonly used it is. So you may be able to tell me once we have the discussion. But we use what's called a CPAP, continuous positive airway pressure mode. This is very different from what we use for the type 2 respiratory patients, like the COPD exacerbations or the obesity hyperventilation, where the carbon dioxide is high and the oxygen is low. So that's the type 2. These patients usually are low oxygen, low carbon dioxide if you do a blood gas. So if you don't have a blood gas, don't even worry. Oxygen saturation is more than enough. So if you find that you've increased your oxygen to about 14, 15 liters, I'll tell you what the devices you can do that. Then we put them on a CPAP or a non-invasive. Just give me a second. I'll just plug my computer in. I'm turning on the power. Okay. So the CPAP mode is what we use, because the problem is type 1 respiratory failure, and physiologically it is gas exchange. It is not bronchospasm. So giving deriphyllin, aminophylline, or salbutamol and all that, waste of time. Don't do it. Give them oxygen. Bring the oxygen above 92%. So your targets for these patients who are otherwise reasonably well should be more than 92%. So you don't want 97% oxygen saturation. 92, nobody will die. So that's what you're aiming for, because they do have a lot of problems. So that's the non-invasive ventilation, which is the after ITU, that's the second level. The third level is your oxygenation itself. So one thing we suggest that you don't do, I'm not sure if you have it, is humidified oxygen, which is called as OptiFlow, is not a useful thing. because it generates a lot of aerosols. It will be bad for the staff. So we don't use that. You can use nasal cannula, which is good, but you can use nasal cannula, it can go up to 5 liters, which is approximately 40% of FiO2 oxygen saturation that you can deliver. We also get large bore nasal cannula. I'm not sure if it's available. If it's available, I think it's a fantastic thing to use because it's very comfortable. It's worthwhile checking earlier if you have large bore nasal cannula. And it's not expensive at all. It's very similar to the small nasal cannula which you put in your nose, but it's larger bore, and you can go up to 14 liters oxygen to that, going up to 60 to 70%. Venturi is the other thing which initially we wondered and we ummed and ahed whether it should be, if it's useful, because we're worried about some of the expiratory leaks. But actually looking at some hard data which came out, we are now started using Venturi. Venturi is when you can give 35%, 40%, 60% oxygen through the Venturi effect, where your oxygen is connected and tells you what is the flow rate. So what I was saying is all of these things need oxygen. Oxygen is if there's one thing all of you should be prepared, it is oxygen. Because the one thing which saves lives is oxygen. Everything else is secondary. So if you can be prepared with oxygen, please do that. Oxygen cylinders will run out in no time. So even if you have a big cylinder, it's going to run out in no time. You might want to see if you're going to be able to pump it in. If you have pumped oxygen, you may also want to see what's the capacity of the pumping. So you may be able to cater for 5 patients, but what if you have 50 patients? Will you be able to manage that? The other thing I was talking to Gokavi and some of the others was whether you can use the oxygen concentrator. So it's a cheap way of producing oxygen because all you need is electricity, and you can generate up to 5 liters of oxygen flow through one concentrator, which means you can give up to 40% through one concentrator. And if you need a higher flow, then you can actually have 2 concentrators and piggyback one to the other. So then you can get up to 8 to 10 liters with 2 concentrators. And some patients, we even piggyback 3 concentrators attached to one another. So you can go up to 14 liters. So that is something which, here at least, it's not an expensive machine, oxygen concentrator, because the principle is very simple, and you don't have to have cylinders and big complex things wired in and pumped in. All you need is to connect. So one suggestion is for people to think how expensive these are, and if you can get a few of them, so that the one treatment for COVID, and all of them are COVID pneumonia, is oxygen. And you need to have the oxygen. Without oxygen, there is nothing you're really doing by keeping the patient in hospital, because you can do the same thing at home. So that is the advice. Would you give nebulizers for these patients? The answer is no. Many of them don't have bronchospasm, and secondly, nebulizers also produce aerosols, and therefore you would not want to give nebulizers. If you have to give it, if it's an asthmatic, you can use a spacer, and then you can put an MDI. That is the thing about oxygen. So what else do we do to treat? The other very easy thing which you can do is to put the patient prone. The prone position, as in lying on your stomach, it's not very comfortable, but your oxygenation can improve significantly with patients. As you know, patients in intensive care, when they need high FiO2, they're usually prone at given ventilation. And we've seen a dramatic improvement in patients who are prone. So you can give high flow oxygen prone, as in lying on your stomach, because what happens is a lot of these the unventilated units in the posterior back of the lung open up when you're prone. And it's very, very useful for these patients. And what we are doing for anybody who needs 8 liters and more, we are proning them, because technically they will qualify as moderate ARDS if you use the FiO to PO2 ratio. I would even suggest that anybody going above 4 liters, which is actually something we're looking at. We're actually currently doing a study looking at some groups with 4 liters who are prone, and others who on 4 liters, between 4 and 8 liters, who are not prone, to see whether they progress to worsening of respiratory failure or the duration is shortened. My feeling is anybody who's prone is going to do better than people who are not prone. So a prone position is better than actually sitting them up in this condition that which we're talking about, the ARDS condition we're talking about. We're not talking about heart failure, and we're not talking about patients with COPD. We're talking very specifically about COVID pneumonia. So that's something which anybody can do, and I would strongly recommend that. So that is as far as management. Now, drug treatment, we don't give specific treatment here other than for on a trial as in through studies. I know in India they're advocating azithromycin and hydroxychloroquine and some antivirals. If you ask me what I think it's a cheap drug. If it's available, I see no contraindication, but very rarely patients can get side effects. So whether it benefits or not, it's difficult to say. Is it very harmful? I'm not sure. I don't think so. So if you weigh the risk and benefit, Jacob John and Sheshadri from Vellore suggested that they would rather advocate giving hydroxychloroquine in the Indian setting, and I'm not against it at all. Please, by all means, give them hydroxychloroquine, but I'll leave it to you. There's no evidence to date. They're doing studies, as you know here. So that's the treatment. Would you give antibiotics? Routinely, no. But most patients, by the time they come to us in hospital, already have symptoms for a week, cough, breathlessness for a week, and usually get secondary bacterial infection in week 2 onwards, which is why we give them antibiotics. So that's something which you can think about. And azithromycin of patients can be given because there is some evidence that azithromycin has got some anti-inflammatory effects as well, in addition to being an antibacterial. So it may be worthwhile considering that if it's available. Otherwise, things like clarithromycin, erythromycin, which is the same family, can be considered. Obviously, we can give them penicillin as well. Penicillin as in amoxicillin or clavulanic acid, whatever you want to is available, depending on the costs and such like. But again, the first week is not really beneficial. From second week onwards, especially if we think that the WBC is going up and the neutrophils are going up, which usually doesn't happen in the first week, then you worry about a secondary infection, so you give them antibiotics for that. When do we discharge patients home? When we wean the oxygen down, usually when they're off oxygen and the saturations are 92%, we discharge them with a saturation of 92%. As I said, we admit them saturation under 94% because they can deteriorate. But once we've treated them, we can send them home with a saturation of 92%, telling them to come back if there is a problem. And most patients don't come back, or hardly anybody has come back. So we are quite happy with the discharge point of view. So I've just told you a bit about what we do with the treatment and cohorting and such like. What about staff? How do you protect yourself? I think it's absolutely important that you protect yourself, and there are specific guidelines. So if you're in an area which is generating generating aerosols, for example, if you're intubating patients, or if you're doing a scopy, which I don't know why you want to do a scopy, but don't do it if you don't have to. Or if you're going to be doing a tracheostomy, which is not a good thing either for these patients in the beginning. Or if you're doing lots of suctioning, then you produce aerosols. And non-invasive ventilation, of course, you produce aerosols. You need to be full PPE, and full PPE means the FFP3 mask or the NP3 mask or whatever is there in your thing. And you need to cover your eyes as well with a visor if you can, or glasses, and with gloves, full gloves and leg covering as well, and your head. So that is what we recommend. And so it's something for you to think about and see how you're going to manage. And can you clean them? The short answer is probably yes. We use our glasses, we clean them with alcohol rubs, and we used to reuse them. Can you clean a mask and reuse it? There have been some studies, well, some looking at, not studies, they've been anecdotal reports saying that you can clean them with alcohol wipes. But whenever you use a FFP3 mask, make sure it's very, very nicely sealed. And the seal usually, you lose the seal when it's reused. So you need to be careful. Don't let it give you a false feeling of protection. Even when you have the FFP3 mask, make sure it's completely sealed. And here we do have what's called as fit testing, which means everybody goes through a mask and they'll give you some aerosols and see whether you can taste the aerosol. And if you can taste it, you fail the mask. So I had a beard, and my beard came off 3 weeks ago. With the beard, you fail the test. So aerosols go in. So any of you have beards, please shave. Is a very simple thing which you need to do. So that is for the aerosol generating places. Once you start filling up wards, it may be worthwhile. So anybody walking through the door today in our hospital is COVID unless otherwise proven. So if somebody is coughing, you're not generating any aerosols by sucking stuff or intubating them, but a cough can produce droplets. So we in the COVID wards, we have full PPE. Everybody uses a full PPE. Is a simple surgical mask useful? It protects up to 80%, which is not bad at all. And some say the FFP3, which is the full PPE mask, will only protect you about 85%. So whether the FFP3 mask is giving you a false sense of security, I don't know, because 3 of my colleagues who went off sick, all of them used the FFP3 mask as well. So something is better than nothing. At least have the surgical mask, which is inexpensive. But if you can get FFP3 mask when you have the COVID wards, please use it, not just for the doctors, for the nurses, but everybody else who's in that ward, because aerosols can remain, especially in closed rooms, for long periods of time. So something to think about, staff protection. Do you test everybody in the community? We don't hear. I'm not sure what the big advantage is other than to know what is the actual prevalence and the number of people who are getting ventilated. But we check everybody coming into the hospital, check it at least once. And we also check healthcare workers, because if they're negative, then they can work if they have symptoms. If they're positive, then it's better that they're not spreading it to others. We send them home. And the same we do for any family member who has illness, to make sure the healthcare worker needs to be isolated or not. We check the family member. So that's what we do here, something for you to think about in your place. So that's what we do for cohorting, what we do for admissions, what we do for discharges. One last thing is, which you need to all decide, is who should be leading this in your hospital. You should have a designated management team, and that is absolutely crucial. And they should take the decisions on a day-to-day basis. And you should all be prepared to change your rules day to day. So the rule on day 1 need not be the rule on day 3. It depends on the number of patients coming through the door, depends on your equipment, depends on what's happening to your electricity or gas or whatnot. You must be prepared to adapt and change. And you should have a core group who's taking the rules. And this group should communicate it to everybody, including the pharmacist and the ward attender, and everybody should know today's rules are this. So everybody is clear of what's going on. Maybe worthwhile training people as well. Mission hospitals will have lots of nursing students and nursing or lab students or medical students even. So it may be worthwhile giving them all basic training on to how to use your full PPE. How do you do basic cardiopulmonary resuscitation? How do you give oxygen? Show them the basic principles of oxygen. Ventilators, if you've got enough people to train, you can pre-train them on ventilators. We have trained about 80 people who are even surgeons and surgical registrars, radiologists and others, to looking at how to handle ventilators, because we have lots of patients on ventilation. So management is very important, and how you communicate. But one thing which Gok said, I think is really, Gogavi said, is very important, because here it's easy, because we have the National Health Service and it's a government thing, so you can easily spread the message across through various bodies which govern. But because you have lots of NGOs and private sector and mission hospital and government sector, you need to look at the health sector in the place that you are, and actually have early meetings and say how you're going to work together and what will be your strategy. And that will be different from each place, depending on how cooperative they are and how much of resources you have, which is very difficult for me to even think about, but you will know what really happens in your local areas. So that is something which is useful well in advance for you to sit and have the discussion, an open discussion. So you're not here to you're here to try and save your patients and to save the economy at the end of the day. It's not for one person's gain or another's loss. It's useful to get that camaraderie together, and if that happens, I think you'll do very well. I think I've spoken quite a lot. I'm going to stop there, and I'm happy to cover other things that you may have questions about. Happy to answer questions. You may all have different scenarios, as in the places that you work in, which I wouldn't know, but if you're happy, if you want to discuss, I'm happy to clarify, discuss, and hope to answer. I can't presume to have all the answers. And as I said, we're all learning. But
Thanks,
it is
Johnson.
Mhm.
Yeah. So I'm going to kind of moderate the questioning a bit. I'm going to look at sort of the sequence at which the questions came in. What I will request is that as I name the person who's asked the question, please unmute your mic and ask the question. The first question has come from John Jacob. Would you please unmute your mic, John, and then ask your question?
I had written a few questions. I'll ask them one by one. So you had said that I just want to, at the beginning, I want to thank you for a good, detailed what is happening there. See, you said you had cohorted the patients from all the other areas to one single area. Did that, and you said initially all the staff are managing COVID. Now, once you cohorted, that means only a few staff are managing them. Is that it?
No. What we did initially, right at the beginning, we had put them in the side rooms.
Yes.
Okay, side rooms in respiratory to start it off with, but they quickly ran out. We went to side rooms each of the other wards. So we have 4 side rooms in respiratory. We had one nurse looking after those 4 side rooms. So they will be donned and they'll be sitting there, and only looking after those 4. And when the medics go to do the rounds, so we used to all not go in. Only one person goes in by wearing that and come back and write the notes with the nurse. So we did that. But the problem was then we had different people. So we had 4 nurses here. We had 1 nurse in each ward actually doing it. We had 10 nurses who were sitting in FFP and 10 other consultants doing it. So we thought if you put, as the patients started increasing in number, rather than having lots of places, you see, it's very easy to slip. We may say that, okay, I'm sitting in the full PPE, but trust me, it's not comfortable. It's not easy. And you will rub your face, you rub your hand. Lots of things we do instinctively are disaster. So what we did was we moved everybody into one ward. And so all the nurses in that ward will be full PE. All the doctors will be full PE. So junior doctors in that ward will not go anywhere. They'll just stay there. So that's how one ward was filled. So when we have 2 respiratory wards, each with 30 beds, 28 beds each. So one was full, one was a clean ward, one was a dirty ward. And then we started overfilling, and both of them became dirty wards, as in COVID wards. Dirty means COVID. And then we slowly started moving patients from doing a next ward and the next ward and next ward. So each of the wards, when they become COVID, that will also be full PPE. And then we started looking at, can respiratory physicians manage everything? No, we can't. So we were looking at, so I said yesterday, I didn't mention it in detail, we have 5 cohorts. So cohort 5 is what's called as terminally ill patients, meaning coming from nursing homes who've got dementia, who's got 85, 90, and they're pretty much bad, and they come here, you keep them comfortable. We have what's called as a palliative protocol, integrated care pathway, and palliative care physician looks at them. So that's called cohort 5, which is a palliative ward. Cohort 4 is the group of patients we will go all the way except for intubation. They can have CPAP, but they will not have intubation. So cohort 4, once we started getting lots of patients, they were moved to the wards which are looked after by general physicians whom we train to look after them. So we have criteria. If they develop this with proning and their saturation is so and so, with 15 liters, move them to our ward, we'll give them CPAP. The respiratory wards are cohort 3, which means everybody in the respiratory wards, the 56 patients, will be intubated if they deteriorate, which means they've hardly any COVID. They're usually in the 40s, 50s, early 60s, who have got significant type 1 failure requiring high flow oxygen. So usually they need more than 8 liters of oxygen to be in my ward. If they're going, then we have the cohort 2 and cohort 1, which are patients who will be ventilated, which means full escalation, but they're not as sick as my respiratory one. They can be 2 liters, 3 liters. So we sort of cohorted them. The cohort 3, which is the sickest respiratory patients who can go up to ventilation, are looked after respiratory consultants. So that's how we cohorted people. And the question you have in mind is what happens to the clean patients if you put them, can you make a mistake and put them into a, if they're not COVID, will we put them into a COVID ward and will they get COVID disease? I think that's where you need to use a clinical judgment. very important, as I said, the clinical features are very, very classical. Fever, headache, you may say it's flu, but fever, headache, body ache, and the classic X-ray features, and which you will see. And lymphopenia and high CRP with a normal WBC is almost certainly COVID, at least here. And I think it can't be very different when it happens there as well, because that's been the picture in China, that's been the picture in Italy, it is the picture in America. So, you know, it's been the picture in South Korea. So it can't be very different, that sort of thing. If you're, you know, which is why it'll be useful to have areas. So if you have only 3 patients, then you better put them in the side rooms and have the other ones as a clean area. If you have 10 patients, then you may have to use the general ward area and say one general ward place will only be COVID. So have the high suspicion ones there. At the end of the day, you may make a mistake, but if the more and more patients you have, the chances are you're not going to make a mistake. I'm not sure if I answered your question.
Yes. Majority, most of my, that is very detailed, especially the cohorting of the patients 1 to 5. That is a very good idea. One more thing, you said that you had the same ER for COVID, non-COVID. So they have different entrances, or they use the same place? Or?
Okay, so again, as I said, over 4 weeks we evolved so much. I can't believe we're in the same hospital, because I've got one of my offices. I've got 2 because my medical office actually is in one of the side rooms. It's an office in a care of the elderly ward. By Monday, that will become an intensive care unit. So it's all completely changed. So when we started in the ER, it was, you know, the patients who are query COVID, so they will be brought in by special ambulance. All the ambulance crew were wearing also, they had a separate entrance. That was a small entrance, the rest of it was the main ER. So when you start off, that's what you should have. You should have a small area where you will only bring COVID patients in, where you must take the precautions and then examine the patients. But as the numbers increase, as I said, most patients, 95% of patients coming into the ER now is COVID. We do have a small area for a stroke patient. So what we used to call as the minors area, we have majors, minors, and resus. That's it, and a pediatric ER. Pediatric ER is still pediatric ER. Most patients who come in are not COVID. The minors area, which used to be for minor injuries, it's now converted into, it's got a separate entrance, and they come in through that. So I didn't say anything about entrances, about people coming in. Now the hospital is like a fortress. Only the patient can come in. You don't even get a patient's relative to come in. Once they come in through the ER door, they are on their own. You're not allowed into the hospital. If you're admitted in a bed, no visitors for the patients till you're discharged. You don't have, because the more people you have in, it's going to be a disaster. Something you must think about. I know in India it's going to be difficult, going to be, you know, there may be problems with, you know, communications, understanding, and whatnot. You really have to put your foot down and only make sure that at best, if they can manage their own language, nobody, because most people have cell phones now. I think even rural areas, they do have it. If they don't, you may want to allow one person into come into the hospital. So ER itself, to start off with, it'll be good to have a separate area for COVID and non-COVID. As you progress, you will, well, I'm hoping you don't progress for everybody's sake. Then you may have to have a smaller area for non-COVID and big area for COVID.
Thank you, sir. One more thing, like you said, negative pressure rooms, you had only 1.
Yeah.
Here also we have none. So
don't worry, don't bother. Waste of time.
Okay. And
don't do it.
Ventilators are also in short supply. Is there any role for bagging them with a vein circuit and having a staff or relative to bag the patient with the vein circuit?
How long can you do that? I see the experience. Once you ventilate them, the patients who do well in 72 hours, you can extubate. So they're talking at least 48 to 72 hours. So I know when I worked in Tiruvalla, we used to have cobra bites, patients coming in, and when our ventilators were full, we used to get families to sit down and bag. Some of these weakness, but it wouldn't take a long time, and so 6-8 hours they used to bag, and by which time it was bad. I'm sure you can try. Necessity, I'm sure, is the mother of invention. So if you have groups of patients who can come and sit down, relatives who can come and sit down. But also remember, if it's COVID, you're actually having a good chance of spreading it to all those people who sit in back.
Thank you very much for the answers. Thank you, Dr. Pramod. You can connect.
Okay, so I'll move on to the next question, which has actually been put forward by Rajiv Chaudhary. Rajiv, are you here? Please unmute your mic, ask your question.
Hi, Johnson. Seeing you after ages.
Is it Rajiv 82?
Exactly.
Oh, hi. Good evening.
Good evening. So I had a few questions. Let me just dig them out and see if I can find them. Yeah, so you were saying that all these other departments, the hospital has become 100% COVID, and all the other departments are kind of shut down.
We have at the moment we have 3 wards out of the 18 wards, which are 4 wards out of the 18 wards, which are medical and surgical, which are purely not COVID. All the rest have, at least 10 of them have mainly COVID, and some of them have few COVIDs. Then obviously the other wards are gynae and such like.
Yeah. So what do you do with all this staff that are there for all the other departments, like the doctors and the nurses, technicians?
They've all been redeployed, hugely redeployed. See, that's one of the fantastic things which has happened in this thing. So I'll start with the trainees, which you may not have many trainees, but you'll have junior doctors. But we have lots of trainees, which are interns and registrars and specialty doctors and such like.
Yeah.
All those from surgery have been, so medicine, they do medicine. So mostly doing respiratory now, because most of them are respiratory patients. So they've all been given tutorials on, this is what, which is why a protocol is absolutely important. If you disseminate it to everybody saying, this is what works, this is what happens if this happens, you move to this, who to contact. Everybody should be clear. The surgical ones were all trained to go to either ITU or to ED. So all of them have been redeployed to intensive care or ED. So a lot of our orthopedic consultants, surgical consultants are actually in our intensive care wards. They're actually running intensive care. And we've trained, even before it hit us, we trained about 80 of them. Our anesthetic intensivists trained them on the basic principles of ventilator management. So they don't have to intubate patients. We have a team who are anesthetists, intensivists who will intubate, stick them on a ventilator, decide on the settings, and the others will sit and manage the rest. So they've all been redeployed. We have radiology registrars, actually gynecology registrars, who are actually sitting in ED and looking at patients coming through the door.
Okay.
So which is why at the end of the day, it's a basic, simple medicine. We don't use a stethoscope. Nobody is examined from the chest. You just look at them, respiratory rate, oxygen, heart rate, blood pressure. That's all you need, and your X-ray.
Okay. So do they have a great fear of coming into these kind of situations where they, first of all, don't have any understanding of the disease, and secondly, they have to deal with something that might be, severely infectious?
Okay. Before it started, we had about 4 meetings in the hospital. 4 meetings where, I'm the director of medical education, so I, along with the ID consultant, with the intensivist and the medical director and trust management, we called in 4 different groups. We called all consultants and registrars, and we told them about the disease, told them what to expect, told them what they will be asked to do. And we explained that yes, it's an infectious disease. But we also told them, 80 to 90% of patients will have 80% will have a mild illness. So that is very, very important, your communication with the staff. I haven't touched on a lot of things. We have protocols for how to talk to patients, protocols of how you counsel trainees, how you counsel registrars, and various other things. But the biggest thing is fear.
Mm.
So it is a responsibility of the leading the senior doctors to actually lead by example and tell them the facts. We're not lying, we're telling them the truth. 80% have mild disease. What we're seeing in the hospital is the 20%. To put it into perspective, I just said this, we have 6 regular consultants and 1 locum consultant. 3 of my consultant colleagues are down with COVID. 2 of them are now improving. And 1 is just started, it's about 4 days ago, 5 days ago. So will I be next? I don't know, but it's possible. But I do know that out of 160 consultants, as of Friday, I think there were 33 or 34 who are down with COVID. And of the 34, about 15, 16 have come back to work. Yes, people, as of yesterday, 19 healthcare workers across the UK have died.
Mm.
So people do die, no question. It's like the flu as well. People do die. More people die with this. But 80% of the people recover. And what is important to tell everybody is, if you get it, it's not the end of the world. And the other thing about communication is, we give them, every day we have a list of people we put on the intensive care. We also have a list of people who've been discharged from intensive care.
Okay.
And from our respiratory wards, we always give them, every day the trust gets information of number of patients I've discharged from each of my ward, or at least our chest team have discharged. And these are very sick patients. And if you look at their x-rays, you would think these people are going to die, but they go home. And so the message should go across that yes, it's a dangerous disease. Yes, it can kill, but the vast majority will be discharged. Vast majority will go home. So it is imperative that you have this good communication across, give everybody. So it shouldn't be they shouldn't be put out there in front without it. Tell them that you're with them, you can protect them, which is why they should also know that you're going to protect them by giving them the PPE, the kits. So do not put them in an area and say, if you suffer, so be it. No. You should be very, very, if you're going to let them go there, you should be prepared to go there.
Within this whole PPE area, there's no PPE available in our parts over here. So we are all producing our own PPE.
We have surgical masks.
Yeah, we have surgical gowns.
Okay, surgical mask is good. Surgical mask gives you 80% protection. So if you're not intubating the patient, or if you're not using NIV or not using a nebulizer, that's good enough. That's good. It gives you 80% protection. Actually, studies for the PPE, talking about the FFP3 mask, is between 85 to 90. So it's a 10% more that you can get. So if you have surgical mask, that's all that you need.
Okay. So these staff who are working in these areas, are they considered exposed, and if they're in PPE, and do they have to be quarantined?
No. I come home every day. I come home every day. It's just that I've taken more showers now than I've ever taken in my life. That's the only difference. So you come home, when you get out of the quarantine, the PP area, you must get off all your, we don't wear our regular, I take off my jacket and the rest of the stuff and leave it in my office, change it to scrubs, the theater clothes. So you must have, that's the other thing which is very useful. Get enough scrubs, theater clothes, and just make it in the hospital, make sure it's washed in the hospital and give it to the staff. So they wear it and leave it behind and wear their own clothes and go home. So even when the other thing you must do is wash your hands, and wash your hands for 20 seconds, very important. So if it's a Christian hospital, the Psalm 23, if you get to verse 3, it's 20 seconds. Or verse 4, half of verse 4 is 20 seconds. So you can all teach to recite that.
Psalm 23 up to verse 4.
So use alcohol gel. I'm sure you can get alcohol gel.
We're making our own.
We have made our own hand sanitizer.
Yeah, hand sanitizer is perfect. When alcohol gel ran out, it ran out of all the shops here, the hand sanitizers. So I told all my registers, go and buy a small bottle of brandy or something like that, and just wipe your hands with that. So you can basically wash your hands, and soap is very, very good. And once you get home, you don't touch your family, just go straight, make sure you have a shower.
Yeah.
That's very, very useful. No quarantine, no.
No quarantine. Okay, good. And there was another question that somebody was telling me that it can get into your oxygen system, the virus. So you have to compulsorily use this fancy filter before it gets delivered to the patient.
We don't actually. Why would it get in reverse into the system? Because oxygen flows one way, isn't it?
I also thought the same thing, but because he threw it at me, I just had to, listen to it.
I've never heard of that before, Rajiv. I've not heard of it. We don't use any filters for oxygen, but we use filters for the NIV machines, because you have the inspiratory and the expiratory arm. But they blow out the expiratory thing, should have bacterial filters. But for oxygen, no, we don't, because it's not it doesn't suck it in. It's not a suction tube. So you need.
Great. Thanks a lot, Johnson.
No problem.
This has been done. Thanks for your time and for giving us this encouragement. We're also getting ready for this. Let's see how it pans out for India.
Don't worry, it'll be fine.
Okay, I think the next question was asked by Sanjeet. Dr. Sanjeet Peters, are you here?
Yeah, PD. Hi, Johnson. This is Sanjeet Peter.
Oh, Sanjeet, 82 as well.
Yes. How are you? Good.
Very
nice
well.
talking. Nice listening to you and getting all the information that you had to share with us. I appreciate your time. As you had pointed out earlier, the slightly less symptomatic or the mild COVID patients are actually sent home in your situation.
Yeah.
Now, over here, the government has mandated that such patients have also got to be admitted. Now, over the next few weeks, we think that this decision will be left up to the individual districts, and therefore the individual district hospitals will formulate a policy for that particular district. In which case, which is because once the cases improve, we obviously will need to send patients home. We can't keep everybody in the hospital. Could age be used as a criteria and say, okay, fine, the young are most likely to get better. They don't need hospitalization, so therefore send them home. But the older ones with some comorbidities, maybe admit them, but not necessarily do we go up straight into the triage up to the intensive care and ventilation for them. Because obviously we want to reserve the ventilators for the people who probably need it.
Okay, I think there are two bits of that question. Is it one is it necessary to keep them in hospital? As I said, if your district formulates a policy, as I said, the reason we do that here is because we know that they can go home and not almost certainly there will be at least there'll be more than one room in the house, and that there are mandated things here for if you have children, you need to have a separate bedroom for them, and there are some criteria. So we know that there are more than one bedroom in the house for anybody who's got children, and if it's just a couple, there'll be one bedroom because every house has got that. So it's easy to isolate here. And as in one person can remain in the bedroom and the other person can make sure that you can get stuff for them and leave it outside. So we tell them strictly what to do, which is what I said in the beginning. In India, it may not be entirely possible because you may not have the facility to isolate them at home, in which case India is probably looking at keeping them in, admitting them to the hospital. So I understand where they're coming from, but you can do that now, now that your number of cases are less. What will you do if you fill up your hospitals with mild cases?
That's exactly what I'm saying. So when that happens, can we then say, okay, at least the younger patients, can we send them home? Because very unlikely that they would become worse.
Well, even the older patients, even the older patients, I can tell you one thing. See, if you look at the trajectory of the disease progression, it's usually the first 7 days which you have high fever. Day 7 to usually by day 7, lots of them are well. Even Prince Charles, who's 72 years old, he got better when day 5 or 6, he was out by day 7. While Boris Johnson, who's 55, he had to be in intensive care. So it is variable. So the normal trajectory is by day 7, most patients get better. And 8, 9, and 10, the fever comes down. So if you have whether it's young or old, if they are not breathless by day 7 or 8, the chances of them progressing are less than 50%, as in worsening. So it doesn't matter if it's a young or old. If their saturations are over 94%, there's no reason why they should be in hospital, because you're not doing anything for them other than what they're doing at home. So other than isolating them, if there is facility to them to go home and stay in a separate room, sending a kid home and sending an older person home, well, you can always try and say, I'll send the kids first home and then I'll send the older people home. But physiologically and, I can't see a difference.
Okay.
Because the kid will be as infective as the older person. And if the older person is well enough to go home, he should be home. And the worst case scenario is them staying in hospital. And if it's in a COVID ward and getting a secondary infection from somebody else.
Yeah.
But I suppose you have to play the rules according to what your district decides.
What the district says, yeah.
Yeah. And as I said, we changed over the last month. The life is completely different. So which is why I think all of you should be prepared about changing your protocols on a even daily basis, because it just changes depending on intensity, availability, and so on and so forth.
Thank you. Thanks, Johnson.
Okay, next question was by Dr. George Philip. Are you here, Dr. George? Please unmute your mic and ask the question.
Yeah. Hi, Johnson. George Philip, batch of 84. I'm in Oranjatra.
Oh, hi, George.
Hi, nice to see you. Thank you for your presentation, your sharing your experience. Thank you for your ideas. We would like to receive your protocols through Gokavi. If you could share with us, Gokavi. The question I had was, we are at the beginning of maybe the coronavirus stage in Dindigul district, Tamil Nadu, and we have a problem at the gate. We have our OP crowd has reduced from 1,200 to about 400 or 300. We have closed many of our wards, but still patients come, and we have difficulty in managing the people at the gate. We are not allowing everybody at the gate to come in, and you had mentioned that we have to close down many of our OPDs. My question is, the people at the fever triaging area and at the gate who are separating the fever patients from the non-fever patients, do they need the extensive PPE?
They don't need extensive PPE because, well, obviously they need to have at least a mask and glove.
Okay.
Okay. So if they can have, I suppose they will be working at a shift of 4 hours, 8 hours, or something like that. Somebody.
Yes.
Okay. So if you can afford, a minimum you should have is a mask and glove. Why mask? Because mask is protecting you 80% of the time, and then you don't need to change the mask between patients. You can change it at the end of the shift, provided you don't rub your face on the mask and rub your eyes and that sort of thing.
Yeah.
So they have to be, you have to be very clear with these guys. The way of transmission is by actually using your hands going anywhere in your mouth, eyes, mucous membranes. So they should be educated first. So once they're educated, if you have a mask and a glove, that's the bare minimum they should have doing the temperature. If do you get this apron, if you can get these in a full, like where the gowns that you wear in theater?
Yeah, the scrubs.
The scrubs, yeah, the full ones.
Okay.
Yeah, the full one.
Gown.
The gowns, yes. So we have the disposable ones here. So there's no harm in using a non-disposable and washing it.
Right.
So if they can wear it, it's better, because you can, again, you can wear all that, and if you do this, you defeated the purpose. So and sometimes we do it by, it's natural. We just do it, and I can tell you the number of times I've had to go back and wash my nose and that sort of thing, despite wearing everything. So gloves because you're going to touch these guys, or you're going to be touching things, and mask, definitely they need a mask, because I'm sure a lot of people keep coughing as well.
Yes. Thank you.
Okay, I think we've covered all the questions. Is there anybody I have missed out? If there is somebody I've missed out, please unmute and you can come up with your question. Okay, So Johnson, I think that was another excellent session, and I think that's excellent sort of heads up you've given everybody. Hopefully our heroes here in the front line, in the remote areas and various places they cover will be better prepared. And I'm sorry, there's just one more question that has come in. Let me have a look.
Yes, sorry.
Okay. So nothing, sorry. And I think that was a very good explanation of what to expect, the stages that they go through. And I think, like I said, our heroes in the front line, I'm sure in the remote and various rural, semi-rural areas they're serving will be better and better prepared now, at least to the best of limits that they can. I really wish them all the best, and please be safe. Yeah. Any other questions, folks?
Hello. Yes. This is Arpit Matthew from Madhipura.
Yeah, please ask.
I just had a brief question. What percentage of patients are children?
It's a good question. The short answer is very few children. One, in the pediatric wards, they are not admitted. They are all treated at home. So the good news is many of them, at least in our hospital, you may have heard of a 13-year-old who passed away in the UK, but it is very unusual for a pediatric patient to be admitted. So as I said, the pediatric ER is still a clean ER, and they call 111 here, which is a NHS helpline, and they advise them when to come into hospital. We haven't had any child on a ventilator here. There are 2 or 3 kids who have, I think 2 who have below 16 who have died in the country. I'm not aware of anybody. So the short answer is very few. I have not treated. I don't look out of pediatrics anyway, but I do know my pediatric colleagues haven't had anybody going to a non-invasive ventilation or ventilation. So that's a blessing in many ways, because you don't want this to happen to kids. Not to anybody, but certainly not kids.
Thank you so much.
One question, PD.
Yes, please go ahead.
What's the purpose of testing the patients who come in?
That's a good question. So, you may turn around and say, what's the purpose of testing, anybody for that matter, if you do have the clinical syndrome. As you know, it's 1/3 of patients are negative, even though they have the classical signs, and we treat them as COVID, and they are in the COVID wards because they can't be anything else. So we don't retest them either. So we brand them as COVID. So all the studies that we're doing now are, for example, the studies we're doing a study with 5 arms: hydroxychloroquine, standard treatment, dexamethasone, antivirals. So the criteria for inclusion is the clinical syndrome, not the positivity. But it's useful for epidemiological reasons to have a viral confirmation as well. So when you have huge numbers, so we don't even bother repeating the test. So the test, in a mission, I mean, if the question you're asking is, in a mission hospital, is it really necessary? I think you will be guided by the national guideline. If the national guidelines says test everybody coming through the door, the short answer is you should. If the national guideline says once you're inundated, are you going to be testing everybody because will you have the reagents? Sort of what test will you be using? Is it the PCR test, or are you going to be using an antibody test? It all depends on whether you have it or not. Our initial tests were just to confirm what we are saying. And now, as I said, we don't even bother waiting for the results. They are triaged as soon as they walk through the door.
So it doesn't make a difference to the treatment, right?
Oh, absolutely not. Absolutely.
Second question, Johnson, about viral load. Are you doing any tests on viral load, and does that indicate how infective a person is?
No, we don't know is the answer. Nobody has done anything about the viral loads. All you need to know is there is 8 viral proteins which are sufficient for you to cause an infection. So there's only evidence to that, because they've looked at that in animal models to see what's the minimum number that you need. But the next question is, what if you get, 1 million viral copies into you and 10 copies into you? Are you going to have a more severe illness? Nobody knows is the answer. Initially, there were thoughts about this because the first person who died was an ENT surgeon. So the question is, are you looking into somebody's throat and sticking the nasopharyngoscope inside? So is it blowing straight into your mouth and did it go in? Well, there's no evidence to suggest that, because the people who are deteriorating and dying are the ones who have the immunological response. And what people still are, confounded is there's no rhyme or reason why some people are mounting this huge response while others are not. So the short answer is, the bigger the load, we don't know. There's no evidence. We do know that we need up to 8 copies, minimum of 8 copies, which is not very much. A droplet will carry that.
Yeah, one last question about this whole new concept about heme and iron and all that. Is that, I mean, why people are not responding to the ventilatory thing satisfactorily? I mean, 52% in a full-fledged ICU is quite a high percentage of death. So does that hold any water? Do you have any opinions on that?
Yeah, I don't have an opinion. And the short answer is, I don't think that's a sound theory. Simply because what we didn't discuss is what happens to these patients on the ventilator. Why do they actually die? Some of them actually, I would say a third of them, they develop such extensive ARDS-like picture, which means they don't have any ventilatory units left. The FiO2 has gone up to 100%. We try them on ECMO, extracorporeal circulation, and some patients die despite that. But a lot of patients are dying for cardiac reasons. So what happens is they do get a degree of myocarditis and get cardiac dysfunction. A lot of the last stages of these patients are they go into cardiogenic shock, and they put them on large doses of NORAD, and you're not able to bring up their blood pressure, and that's how they actually go up. So there is a knock-on effect on the cardiovascular system as well. And it's not just the respiratory which is happening. It is the cytokine storm which actually causes inflammation and damage of various tissues, primarily towards the end becoming the alveolar epithelium and your myocardium. So there are lots of postulates. I suppose time will tell. And we are looking at things like, one of the postulates is hydroxychloroquine and how it acts, and talking about heme and such like. So we don't know is the answer. Possible, but I don't know.
Thanks a lot.
Okay, I think sorry.
Arpit Matthew again from Madhipura. Sorry to just, I have 2 more questions. One is, what antivirals are you using? And second is, are you using any steroids? Some articles are coming about low-dose steroids and
we don't use any specific treatment in the UK, only supportive treatment. We have a study going on called as the recovery trial, and the antivirals which are part of the trial are ropinavir and ritonavir, 400 milligrams and 100 milligrams given for 10 days. We also have an arm which has interferon, 0.5 ml once daily for 10 days. It's got 5 arms. The other one has got dexamethasone 6 milligrams orally or IV for 10 days. And the 4th arm is hydroxychloroquine. So to answer your question, do we give everybody antivirals? No. Antivirals are only given in patients on a study.
And I suppose steroids also only on a study, not for everybody.
Yeah, not an IV. There is some, I'm not sure if you're aware that Epen's postulation about low-dose steroids and giving plasma exchange. Yeah, so there is some interest in it. Again, there is a nice, well, 2 days, I think 2 days after Epen's paper came online, there was a nice article on editorial and critical care saying that it's a good theory, and because Epen's study also shows that they've used it in acute liver failure patients, and they postulated the same could happen in the lung, and which is very plausible. And what the conclusion of that was, we need studies to look at it. So can we start doing it on a case-by-case basis? I suppose you can, but in the UK, we are regulated by a number of regulatory bodies, which will not allow us to use a treatment other than in the research setting.
Thank you. Yeah, that's very helpful. Thank you.
Okay, so Johnson, there's a request for you to, probably send over the protocols, what you feel comfortable sending over. Probably Sunil will be able to, sort of direct it in the right way. Yeah.
I've just put my email onto the chat site. Those who want it, please send to email, because Johnson has sent me 10 things. I think that's the same thing you shared with Vellore also yesterday, right, Johnson?
I will look, because I think I shared most of the things with you, which I shared with Vellore.
I've got 10 attachments.
Okay. So I think that will be the ones which I have spoke to Vellore as well and shared it on a PowerPoint. Yeah, I think if you send that, Gox, that's got, I'll when I get back to work tomorrow, I will look at what I sent you.
Sure.
And if there's anything new coming up, I'll send it to you if you want, and you can send it across. Because all these things what I'm sending across are not copyrighted. They're all, to be used for whatever way you want to use it.
Thanks. That's great.
Okay, folks. I think that covers all the questions, and anybody who had to ask something. Sunil, would you like to close and give a closing remarks?
Yeah, I think, yeah, we're really, really happy that Johnson was able to take this. And I trust that, this is more of the practical, on the ground kind of thing that we've talked about, which you will not get from a regular, webinar or seminar, etc. And I think this is the kind of discussions we need to keep having. As he said, protocols will keep changing, and what is practically possible within our settings, we are very limited. So we need to be very specific about how we can do that. A real appeal is for you to approach the district administration with the thing of saying you have a plan and you'd like to work with them. So the whole area should be thought about, and not just the hospital. So these are some of the things that I think will be very useful for all of us. So thanks so much, Johnson. It's been really good. And I trust the recording can go to many more, and others also can be benefited from this. And would you be free to do this, 1 or 2 weeks down the line if cases start coming in and then we need?
Yeah, I'm happy to do. I was going to suggest 2 things. One, if you want to have it in a couple of weeks or that sort of thing, I'll leave it to you to contact me as the need arises. The other thing is, if the others want to have my email as well, feel free to share my email, because if you have specific questions that you want to ask, little details, because obviously we can't cover everything in this sort of time frame. I'm happy to, have a, reply to you. Gox, you've got my email. I'm happy for you to share.
Sure. Great. So thank you so much. And thanks all for joining in. A little late for us, but I think it's been well worth it. And I'm sure that we can look forward to more sessions like this. I do believe, the Christian network is key to what can happen in the rural parts of India, simply because of our presence there. And we need to take this as seriously as possible. And God willing, we will make a difference in the country. Thank you. Good night to all.
Thank you. God
bless.
bless.
Thank you, everybody. Again, Johnson, thanks a lot. And it's an excellent session. The recording will be available in about 1 hour's time in the Christian Hospitals WhatsApp group. Thank you, everyone, and good night.
Thank you. God bless. Bye.
Stay safe, be healthy.
And pray for one another.